U.S., we're hoping for some orderly flow of people to the U.S. so that our planning can take care of everyone. If there's a total open door, the system will go bankrupt. We will not be able to give good care. So we can't let that happen. I would submit that each country has got to take responsibility for their own citizens first. We can reshuffle all of America under NAFTA. But that reshuffling has got to go slowly, or it will create too great an economic burden for one country.
Okay, we have a call now from Mexico, from UNAM, the Facultad de Medicina Veterinaria y Zootecnia. Welcome. Your question, please.
Sí.
Yes.
Buenos días.
Good morning.
La pregunta es la siguiente.
This is the question.
¿Qué podría recomendar
What could you recommend to the healthcare administrators, for the public healthcare administrators in Mexico, so that the promotion improvements do not stop at the advertising level and could actually be put into practice?
Well, that's a loaded question. I don't want to give the impression that I have all the answers for Mexico, but one thing I am struck at, and we have a problem here too, is an oversupply of doctors and too many medical students. In planning to make the proper match between the health personnel and the needs of the public, we have got to look very closely at the number of doctors we need for the public and not train too many medical students. So let's start right from the beginning. We have to cut the practice of allowing unrestricted medical students in the first year of school. In the old days in Mexico, I understand that as many as 4,000 students could apply at UNAM, and yet at the second year only 1,000 or 500 would be less. We have to have competitive examinations so that, as I've mentioned before, a person can democratically compete for the first year medical student place, and that number be fixed by administrators so that there's an orderly flow of medical students into practice, rather than having an excess number of doctors graduate after 5 years and have no jobs. The same for nurses, which we know we need in Mexico. But every one of the administrators should look hard at matching the need of the public to the flow of personnel to meet that need and make the necessary adjustments.
We have a call now from Panama, from the Universidad TECNOLOGICA de Panama. Welcome. Your question, please.
Muy buenos días.
Good morning.
Un saludo desde la
Greetings from the Universidad Tecnológica de Panama.
Con las demandas legales de mala práctica médica.
With the legal
Restricción en la
suits
derivación
for
hacia los
malpractice
especialistas o centros
and
hospitalarios.
the pressures towards specialists and hospitals, how could this increase the costs based on the administration liability while they try to reduce the costs?
Right. In Mexico and perhaps some other Latin American countries, the doctors have it easy. There's no malpractice suits. And so the cost for that insurance is low. Here in the U.S., we're court and legal proceedings crazy. So there is a very high cost for the insurance to protect against malpractice. Actually, that isn't a very large number, and limits are being set by state legislatures on the awards. The public needs to be protected. They need to be able to sue a doctor or a hospital if a bad practice has occurred. But again, society has got to allow some common sense and limits on the penalties, because usually the parties, the doctors and the hospitals, are trying to do a good job. So the public has got to show some restraints even when some punishment is indicated.
We have a call now from Aguascalientes, Mexico, from the Universidad Autónoma de Aguascalientes. Welcome. Your question, please.
Yes, good morning. My question is related to the fact that the managed care model, how could you involve or incorporate the preventative aspect and some other techniques such as just-in-time services, some modern administration techniques to reduce the costs of services in the countries where the economic aspect is very restricted?
Okay.
Well, this is a crucial question, excellent question, and I say hello to my friends in Aguascalientes. I was there just a year ago. It is critical to incorporate preventative medicine planning into any managed care model, any health model, because I believe what I hear decade after decade, that the only way to conquer disease is to prevent disease. So if we have a certain amount of money for delivering health care to the population, the planners must set aside a large amount of that money for preventative measures that involve the entire public, because that will reduce the incidence of disease and pay benefits later by reduced hospital admissions, reduced expenditures for very high-level care. So prevention is really one of the founding building blocks of any medical care model.
We have a call now from Las Cruces, New Mexico, the New Mexico State University Conflict Resolution Center for U.S. and Mexico. Welcome. Your question, please.
Good morning, gentlemen. Here in the U.S., in what ways would the HMOs have to change to survive into the 21st century?
Well, one of the ways they change, and if you, again, I'm not a big expert on Kaiser, as I have not worked in the Kaiser HMO method, but one way that I've heard that even they change is to give direct access to specialists for certain cases. I'm a neurologist. I take care of patients with multiple sclerosis. If I was in an HMO system that usually insisted that the patient first go to a general practitioner and try to do as well as he can with a general practitioner, and then perhaps later, if things didn't go well, he gets to see the specialist. The public is happier that if in certain highly selected instances, their HMO system will allow them go directly to the specialist if they have multiple sclerosis. So that's one way that an HMO can adapt. And in general, the key is adapting to the patient in responding quickly to whatever his needs are. These large HMO systems have had difficulty with that, but they're getting much better as the competition with more open private systems is improving.
We have a call now from Mexico, DF, from the Continuing Education Center at the Instituto Politécnico Nacional.
Bueno. Sí, Mire, estamos de acuerdo en el servicio integrado de
We
salud,
agree with
pero
the managed
realmente
care
nos
service.
parece que no están
However,
viendo
we
lo
think
esencial.
that you're not going
Lo
to the
esencial,
basics.
fundamentalmente, es
The
que se cubra
basics
toda la
is to
población.
cover the whole population,
Estamos viendo
and
que
what
la
we're seeing
privatización
is that
y el enfoque
privatization
económico que le están
and the
dando
economic
es excluyente, no
approach
solo
that
para
you're
México,
giving
sino para
is
Estados Unidos
excluding
en general.
not only to Mexico but to the U.S. in general.
Si hablamos de administración,
So if we are
creo que
talking
el primer
about
punto es que hay acceso
management, I
de
think
toda la
first we
población
need
al sistema de salud.
access
¿Qué opina usted?
from the whole population to this system. What is your opinion on this?
Well, I didn't mean to imply that there's denial of access to anyone. That in the managed care model, the funding mechanism or the population from, let's call it the public sector, they get their funding from such and such a source. That source of patients and its funding mechanism can be included into any healthcare delivery system. They just arrange for a contract with the healthcare delivery system. Let me give you an example. I work in a hospital system that has 7 hospitals, 1,300 beds, 1,100 doctors, and say 600,000 patients. A large segment of those patients are indigent or have their medical care supplied by Medicaid, the state system. They blend in, the patient blends in seamlessly with our other private patients. They get the same care, it's just that their funding source is different. So I don't see that we are denying anyone care.
We have a question from Tampico from the Universidad Autónoma de Tamaulipas. Welcome. Your question, please.
Yes, first of all, good morning. I would like to know how important it is the workload for the doctors in the personalized care of the patient.
Well, the workload for the primary care doctors is enormous. With the shift from specialty to primary care control, see, currently the managed care model is trying to have the primary care doctor control the whole treatment of the patient regardless of what's wrong with him. The workload for that primary care doctor is now enormous. He has to start work at 7:30 in the morning and work into long hours, has to do paperwork, phone calls, and for the amount of reimbursement or fee that he gets for doing that, it's a very difficult burden. Now, some of the specialists, on the other hand, are not working hard enough. There's too many of them. So there's a tremendous realignment of workloads, with the primary care now very heavy and overburdened, the specialist somewhat underworked, so to speak.
We now go to Huamuchil, Mexico, the Colegio de Bachilleres, Estado de Sinaloa. Welcome. Your question, please.
Good morning. What can we do as patients and health institutions to prevent the medicine to get sick, since we've talked about, on one hand, high costs for the services, and on the other hand, a trend from the user to think that the more medicine and the more services they receive, the healthier they are?
Right, that's a tough question, and I think that you'll see will be answered a little bit better in module number 2. It basically has to do with patient and physician activism. I think in every community, every state, every type of healthcare system you and I are working in, we should try to almost start with a clean slate. Let's ruthlessly look at the system we work in and see if it's meeting the need. If there's certain sectors that are not getting proper attention, then deliberately go out and cultivate them and ask for their input. Let's take the patients. Maybe the patients in the public sector are too timid. They get the care for very little cost. So why should they speak up when they're getting this great gift? No. Encourage them to form alliances, public forums on their input about what they want. That's going to help the administrators, I think, improve the delivery plan.
Let us now begin with Module 2, in which Dr. Nelson will tell us about an exciting new global model for the delivery of health care.
In the preceding module, we examined the trends towards the increased emphasis on managed care in the U.S. industry and finished with a bit of frustration by doctors over this increased control of them by large hospital networks, insurance companies, and the government. At the same time, they see the public anger over the restrictions to access to specialty care. That's the good news. We know that the public out there still wants us. And then another thing that they notice, as the hospital census decreases to 50%, as more of the physician's activity can be performed in an outpatient arena, they now realize that they have increasing control over the outpatient management of patients. The goal now is that if they were more organized or had better organizational skills, since they control the patients, not the hospitals, it appears that we now will have an emerging trend whereby the physician will be in considerable control of the delivery of health care. Now, what we're going to do then is to re-examine the ways in which physicians and groups of physicians interact with their hospitals. They're realizing that we must be more involved with decisions regarding all aspects of hospital care, right down to the intimate details of direction and budget preparation of what goes on in the hospital. Let's first look, before we examine the actual type of partnership that we will be proposing for part of San Diego County where I live, an area of 2.5 million people. Let's look at the next figure that describes the assumptions that will be shaping the future delivery of health care. We see that in the middle of our new relationship between hospitals and physicians, we still are concerned on the upper right-hand portion of the growing corporatization of services. That is, large conglomerates bringing hospitals together into huge entities. We are concerned about the continued competition between hospital groups, physician groups, and how that might negatively impact access for the patient. At the same time, we know that the population is aging, and yet even though the population is becoming older and older, there is a strong emphasis emphasized on the left-hand side of healthy lifestyles. Everyone wants to extend their life as long as possible and in a healthy style of existence. We still have the cost containment pressures, and the relentless improvement of technology that is highly desirable also continues. In the next figure, we see what the customer really wants in the way of care. We know the variables that are approaching us and will continue, but what the payers want in the center is a strong base of primary care access. They want a doctor near them, who's close, and who's interested in them. Around that primary care physician base is a strong cadre or group of specialists that can provide the highest technological advances for some specialty problem that the patient may have. And around that entire ring of primary and specialty physicians will be certain phenomena, let's call them, or certain categories of care that must be present in order to approach all elements of total health. That is, to have an acute care facility. We still need the big hospitals. We need tertiary or quaternary care. That means the highest technology of care possible. If you need a liver transplant, the system somehow must get you a liver transplant. We need the ambulatory surgery phenomenon to continue. That has been excellent in a cost-effective ways. We need good long-term care. As we get older and we eventually become disabled and unable to care for ourselves, the system must build in long-term care facilities. We need case management. This is controversial to doctors, but case managers are people that keep track of what is happening to the patient, his financial situation, his social setting, and assist the physicians and the hospitals in managing the case. Some doctors think this is redundant or excessive to what they do, but at any rate, some of the new care systems build that in as an important component. We need pharmaceuticals, of course, and we want the pharmaceutical industry to continue its excellent progress and production of high-tech chemicals that can cure cancer, stop AIDS, and the like. We also need rehabilitation, and we need home care. We can't think just what happens in the hospital or in the high-tech rehabilitation facility, but we want care perhaps to even start in the home. That's where the patient lives. And this also brings up the whole aspect of responsibility. We want patients to be responsible for themselves. They can access these wonderful components of the system I've described, but on the other hand, they may even choose alternative care. A program was produced here that even discussed Qigong and acupuncture and alternative measures. This could fit into a comprehensive care plan because basically the patient still is responsible for his choice. I think the key there of incorporating all of the practitioners of all types into a care system is that we each know our limitations. I hopefully know my limitations as a neurologist. I won't be very good at gynecologic care of an ovarian cyst, I can guarantee you. If I am an acupuncturist, a chiropractor, or a homeopathic physician, I hope I will know the limits of my province, of my ability to care, and promptly refer the patient if he appears to have an illness that requires some other high-tech solution. Now, what we will be showing to you is a system of care that is what's called strongly vertically integrated. The next figure lists some of the same components that I just discussed, but what we mean by vertical integration is that the integrators and planner must figure out a way in which all of the components interact with each other. So whether it be mobile services, transportation services of getting disabled patients to the hospital or the outpatient facility, whether it be home health services or immediate care, all of this must be vertically integrated. Well, how are we going to do this? Let's look now at the way in which physicians and hospitals work together. As I mentioned, we will end up today with a system that has the hospitals and the physicians linked together in a working model that will be far closer than ever before. The next figure shows the traditional system we've been talking about, the hospital in one arena, the physicians on the left owning whatever type of facility they had, making whatever money they could from billing for their care, and the same for the hospitals. But as you see at the bottom, the hospitals were creating outpatient facilities. At the same time, the doctors were creating outpatient facilities and other ancillary or high-tech types of care. So in many ways, they were competing with each other, and the same excessive cost, reduplication of facilities that we talked about earlier was working. Now on the right-hand side, in our new type of health system, some have called it a staff model, we see that the physicians in the hospital have combined to oversee or to share the development and actually the revenue, the dollars from the care. This is a very simple start to what I'm going to say, but at least gives you an idea, hopefully at least, of togetherness, that we must do all of this together. If you are in the audience and you're a hospital administrator, and yet another one sitting next to you is a general practitioner that is 50 miles away in a rural area, you should look at each other in the eye right now and say, how are we going to come together? Well, doctors in the past have, as we have mentioned earlier, been rugged individualists, have enjoyed being in solo practice, then they would get together in small groups, then finally single specialty groups, multi-specialty clinics, Mayo Clinic. Well, in our community we have a smaller version. We have my next door neighbors called Specialty Medical Group, 50 doctors of all specialists. They seem to have a very well organized operation. Then we developed a concept called management service organizations, where, well, there were too many of us. We were 50 of us doctors. We can't keep track of our overhead. We want to practice medicine and not worry about hiring our employees. So we developed management service organizations. So for, say, 15% of all of our revenue, we would allow an administrative organization to take care of all of our overhead aspects. Rent us the space, hire the employees, take care of the retirement plan. But even there, we are finding that this is costing us more money than we think we should be able to pay. Another type of phenomenon that we hope we can integrate into this new health partnership. Finally, then we have evolved a concept of a integrated health system that is organized in such a way that the hospital and the physicians are together. The next figure shows how the board from the community, the governing board, oversees the health system, while the hospital and the physicians are two major partners and components of that health system. This is going to happen in our community at Scripps, where I work, where we have 1,100 doctors, 1,300 hospital beds, 7 hospitals, 2 nursing homes, a large home health care delivery organization called Scripps Home Care. We are going to take that hospital bricks and mortars institution and radically combine it with the 1,100 physicians into a new type of health structure that will have equal participation by each of us. This is radical for the hospital. Our hospital board has stunned we physicians by the chairman of the board saying, "We hereby empower the physicians to lead Scripps into the next century." Well, this has been a wake-up call for us. The hospital is doing this because they're losing revenue. Their beds are empty. And we all realize, like never before, that we've got to come together to define and administrate this integrated health care delivery system that the public wants. The revenue streams of such a partnership are outlined in the next figure, where on the left again we see the old traditional model of a poorly integrated system, the payer or insurance company directing funds simultaneously to the physician in the hospital who may or may not be in some type of contract with one another. But in this highly integrated system, the money from the payer goes directly to the system, and from there, the system, which consists of half doctors and half of the hospital administrators and teams, decides what dollars will be doled out or contributed to hospital business and then to physician business. A diagram that illustrates our final partnership then between the doctors and physicians is in the next slide, where we call this Scripps Health system, which a 50-50 partnership of the Scripps Health physicians and Scripps Health, which is the hospital system. This will possibly have a management company that arranges for the capitated insurance plan that we mentioned, but will also interface with other insurance companies. Possibly even, in a sense, we will self-insure. In other words, we will have a private contract with one large insurance company to underwrite the